The following podcast is part of a certified educational activity titled Integrating the Latest Evidence into Practice, Expert Insights on Targeted Biologic Therapy for Pediatric and Adult Patients with Moderate to Severe Atopic Dermatitis. Access the entire activity and complete the post-test at peerview.com/RSD860. Downloadable slides are also available.
Hello everyone, my name is Lisa Beck. I'm a dermatologist and I practice at the University of Rochester Medical Center in Rochester, New York in the USA. I'm really happy to talk to you today about new biologics that are being used to treat our patients with moderate to severe atopic dermatitis. We will highlight some of the new abstracts that we've seen at recent meetings. The prevalence of atopic dermatitis is estimated to be about 15 to 20% of children and 1 to 3% of adults. The disease course for atopic dermatitis is commonly chronic in adults and more relapsing and remitting in children. The burden of symptoms can be quite profound with this disease, adversely impacting quality of life. Also, depression, anxiety, sleep disturbance, and other atopic conditions are frequent comorbidities. Systemic therapies are commonly used for patients with poorly controlled moderate to severe atopic dermatitis and impaired quality of life. On this slide, we show you the anatomic distribution of atopic dermatitis by age, going from infant on the left to childhood in the middle and teenager adult on the right. And you can see that the anatomical area where the lesions are seen does change as a function of age, with more cheek and face involvement, often scalp involvement in infants and extensor areas, and then moving to flexors sometime during childhood, often around 2 years, but sometimes a few years after that. And then dominantly flexural areas in the teenager and adult, often with significant hand and foot disease as well. So the pathogenesis of this disease is very complex, and this slide tries to simplify it, but we think it's an interaction between the epithelium, the immune compartment, sensory nerves, and the skin microbiota. We're not sure which of these really initiates the disease. We know that they are dynamically interacting, and we know that the immune deviation that's so characteristic of this disease is what we call type 2 inflammation, initiated by the actions of ILC2 and promoting the development and recruitment of Th2 cells, basophils, eosinophils, mast cells, and dendritic cells, as you see here. We're going to talk briefly about the guidelines that have been proposed across the US, UK, and Europe for treating moderate to severe atopic dermatitis. So on this slide, this is the so-called AD Yardstick, and this helps you to identify what to do when you have someone with moderate to severe atopic dermatitis, despite the use of topical anti-inflammatories such as topical corticosteroids, topical calcineurin antagonists, and topical phosphodiesterase inhibitors. After you've initiated those and tried a number of standard measures to improve skin health, if you are still moderate to severe, it's appropriate to refer that patient to a specialist and consider more aggressive therapies such as phototherapy or dupilumab or systemic immunosuppressants, many of which are not approved in any country in the world. Cyclosporin is the one that is approved in a few countries for the treatment of atopic dermatitis. And you see we also do have to use methotrexate, mycophenolate, azathioprine, and on rare occasion even systemic corticosteroids. Any of these systemic immunosuppressant therapies are usually used for short trials, and you try to reassess them after a month or a month and a half. Okay, and now we move to the 2020 task force paper discussing how to manage atopic dermatitis in both children and adults. And this is organized at the bottom of each of these with the blue box referring to baseline therapy and moving to green for mild disease, yellow for moderate, and red for severe. As you move up, we move to more systemic therapies. And I've put in red a couple new therapies that have recently been approved in various countries of the world to treat atopic dermatitis. So we have now, for mild to moderate disease, topical ruxolitinib and delgocitinib. This is approved in the US and in Japan. And then when we get to more severe disease, in addition to the things I mentioned on the previous slide and dupilumab, we now have in a few countries the use of oral JAK inhibitors, baricitinib and abrocitinib. And in Europe, we have the new biologic Tralokinumab that blocks IL-13. So as you can see in both children and adults, as we move to greater severity, we have to invoke more systemic therapies to manage these patients adequately. So the purpose of this talk will be to update you on biologic approaches to treat type 2 inflammation that we think is characteristic of most of our patients with atopic dermatitis. So moving first to the approved worldwide biologic called dupilumab that targets IL-4 receptor alpha. This is approved in the US, UK, and Europe all the way down to 6 years of age. And this biologic targets the subunit IL-4 receptor alpha that's common to the type 1 receptor and the type 2 receptor. These are the receptors that the cytokine IL-4 and IL-13 act through. So this effectively blocks the biologic actions of both of these cytokines. This drug can be used with topical corticosteroids, and its most common adverse events include injection site reactions, dry eye, conjunctivitis, blepharitis, eye pruritus, and oral herpes. Now moving to a biologic that targets the cytokine IL-13. So this would be specific to 13. This has now recently been approved in Europe and the UK in June of this year to treat adults with moderate to severe disease. And what I'm showing you here are the two identical pivotal phase 3 trials called Extra 1 and 2. Extra 1 data is seen on the left and 2 is on the right. And what you're looking at the top graphs is the percentage of patients who had a drop in their IGA score to 0 or 1 with a 2-point drop. And you can see these two trials do differ slightly for reasons that are not clear, where the Tralokinumab effect in Extra 2 seems to be slightly more beneficial than was seen in Extra 1. At the bottom two graphs, you're looking at the percentage of patients who achieved an EASI-75 or a 75% improvement in their baseline EASI score. And again, we see similar efficacy in both, but slightly greater efficacy in the Extra 2 study. With these studies, the most common adverse events were upper respiratory tract infections and conjunctivitis. So on this slide, we're looking at another anti-IL-13 biologic called lebrikizumab. This is the phase 2b study. The phase 3 study is now completing. We anticipate hearing some of that result in the next year. This is looking at multiple readouts of efficacy at 3 different dose and schedules of lebrikizumab, as seen by the colored lines. We're looking at the percent of patients who achieve an IGA 0/1 in the upper left, those that achieve an EASI-50, EASI-75 in the middle and the right, and then on the lower left, those that achieve an EASI-90, and then those that have a percent change in the pruritus numerical rating scale, and those that achieve a greater than 4-point drop in that same pruritus scale. So you can see good efficacy is observed by 16 weeks, which is statistically different than the placebo group for each one of these readouts, and there appears to be a dose effect. Most common adverse events were upper respiratory tract infection, nasopharyngitis, headache, injection site pain, and reaction. So as I mentioned, the lebrikizumab phase 3 trial, which is called AD-VOCATE-1 and AD-VOCATE-2, has not read out in a peer-reviewed fashion, but we have preliminary evidence that they have met their primary efficacy endpoints at 16 weeks, which was IGA score of 0 or 1 with a reduction of at least 2 points, and an EASI-75. They also achieved secondary endpoints, including early onset and skin clearance, itch relief, improvement in interference of itch on sleep and quality of life. So we look forward to seeing these results in future congresses. I show you here the New England Journal paper on nemolizumab treatment of a Japanese population of adults with moderate to severe atopic dermatitis who were randomized 2-to-1 to nemolizumab versus placebo. As you know, nemolizumab targets the anti-IL-31 receptor alpha, and the primary endpoint was looking at the change in the visual analog scale, or VAS scale, at 16 weeks. And you could see that nemolizumab-treated subjects clearly pulled away from the placebo-treated subjects in the upper left. If we go to the upper right and look at the improvement in EASI score, the signs of the disease, we notice that there isn't as dramatic an improvement seen with the nemolizumab group versus the placebo group, although it is still numerically superior to placebo. If we now look in the lower left graph, which actually looks at the first 15 days of treatment and highlights that the improvement in itch as measured by the VAS score is actually quite robust and very early in the nemolizumab treated group. And then moving to the right, looking at an insomnia severity index to try to address any improvement in sleep achieved with nemolizumab treatment, you can see that there is a very early separation of the nemolizumab group from the placebo group, suggesting that it does help with insomnia. The most common adverse events in this trial were nasopharyngitis, upper respiratory tract infections, worsening of AD, increased CPK values, and injection-related reaction. So now let's go to what are some of the abstracts that were at the recent congresses, the World College Pediatric meeting and the EADV meeting. Here I show you an abstract presented by Dr. Michael Cork at the WCPD meeting. He reports on the long-term treatment efficacy of dupilumab in the children 6 years to 11 years of age with moderate to severe atopic dermatitis. These patients were dosed weight-based, and on the left we're looking at the percent of patients who achieve an IGA 0-1 with a 2-point drop. And you see much of the benefit we're observing is achieved by 16 weeks, but there's a continued slow improvement out to 1 year of time. If we now move to the right graph, looking at the mean percent change in eczema area and severity index, again we see much of the improvement can be seen by 16 weeks, but there appears to be a continued improvement that occurs all the way out to a year of time. If we now move to an abstract by Dr. Amy Paller that was presented at EADV, looking at the same age group and at the primary study, the Liberty AD PEDS trial, she looked at patients and characterized how much different signs of the disease improved, looking specifically at improvements in erythema, infiltration papulation, excoriations, and lichenification, and asking whether they were significantly improved in the dupilumab-treated group by 2 weeks or 16 weeks. And all 4 of these were significantly improved by 16 weeks, and 3 of them were significantly better by as early as 2 weeks: infiltration, excoriation, and lichenification. So very exciting to see that the clinical signs of the disease in this age group, this young pediatric age group, changes very early. On this slide, we're showing the abstract by Dr. Stefan Weidinger, who looked at the same pediatric population, aged 6 to 11 years, treated with dupilumab as part of the Liberty AD PEDS trial. Considering the Treat to Target initiative, which is an international consensus to guide decision-making for treatment choices that suggests using both a patient global assessment plus a disease-specific outcome domain, they developed what's called the composite endpoint. This required a 1-point reduction in the patient global impression of disease, PGIS, and one of the other changes you see below. So taking this composite endpoint, at week 16, they observed that 86% of the dupilumab-treated children reached that composite endpoint versus 39% of placebo-treated patients, suggesting the vast majority of dupilumab-treated children achieved a good outcome at 16 weeks. Moving on now to an abstract that I had presented, looking at the long-term use of dupilumab in adults with atopic dermatitis And these patients were followed for up to 5 years in several countries. And the purpose of this was to see whether the benefits of dupilumab are sustained that far out. So what was observed at 5 years of treatment was that almost 99% of patients had a 50% improvement in their EASI score, 94% had a 75% improvement, and 82% had a 90% improvement in their EASI score. Similarly, very impressive improvements were seen in drops in the peak pruritus NRS score, whether you looked at a 3-point or 4-point reduction. And the adverse events seen in this long-term 5-year study were similar to what had been seen in earlier pivotal trials, and very few patients discontinued the drug because of drug-related side effects. This is an abstract by Dr. Eric Simpson, who looked at 2 new ratings to assess improvement in dupilumab therapy: the patient rating of well-being and a patient rating of their perception of treatment. And in both, the goal is to achieve a very good or excellent rating. He looked at the Liberty AD Solo Continue trial, where patients were treated for up to 1 year. At 52 weeks in this monotherapy trial, he found that 71% of the patients responded to say that they were very good or excellent in their assessment of well-being, and similarly 78% thought the treatment was very effective, giving it a rating of very good or excellent. This was in contrast to 21 and 27% in the placebo-treated patients. So another metric that's valuable, that's very patient-focused, demonstrating that dupilumab is really very efficacious. In this trial, presented by Dr. Andy Blauvelt, looking at long-term control achieved with Tralokinumab, which is the biologic that targets IL-13, on the left, you're seeing the median improvement in EASI from the parent trial baseline from the phase 3 Extra 1 and 2 trials. And you can see that there's continued benefit seen out to 1 year of time. Patients were allowed to re-enroll in a trial called ECZTEND to see if that benefit continued for an additional year of treatment. And you see the different color lines represent how long was the lapse between the Extra 1 extension and the ECZTEND trial initiation. The observation here is that the benefit seen in the first 52 weeks persists in a subsequent year of treatment. On this slide, I'm showing an abstract presented by Dr. Robert Sidbury, looking at a small open-label trial with Nemolizumab in an adolescent population with moderate to severe atopic dermatitis. They followed these patients for 16 weeks, and they were allowed to use background topical corticosteroids and topical calcineurin antagonists. They assessed EASI, peak pruritus NRS, and sleep disturbance, and saw that there was an improvement at week 16 in each one of those. But again, there's no placebo control, so it's a bit hard to say how robust this observation is. And I thought it was somewhat interesting to see that there was such high variability in the improvement in each one of those metrics. They observed that adverse events were primarily mild or moderate in severity, consistent with other trials with nemolizumab. So on this slide, we're looking at an abstract presented by Dr. Bouaziz, looking at the decrease in various signs of atopic dermatitis as a function of nemolizumab treatment, trying to address whether nemolizumab is in fact helping with the underlying inflammation that we think is important in causing the skin features. So this was a post hoc analysis of a phase 2b trial. These patients did get a loading dose, and they were allowed to use topical corticosteroids in both the placebo and the nemolizumab arm. And what they looked at were individual composite scores from the SCORAD assessment, which looks at edema, papulation, erythema, excoriation, lichenification, and oozing crusting. And they did see that the percent of patients who were absent or mild on any one of those readouts at week 1 were somewhat more significant in the nemolizumab treated group than the placebo treated group, as you see in those percentages. Those improvements they saw at week 1 continued to become more significant by week 16. They again saw no new adverse events in this trial to report. On this slide, we're showing an abstract presented by Dr. Robert Bissonnette on a new biologic, Spesolimab, that targets the IL-36 receptor. This was a phase 2A proof of concept study and primarily was looking at easy readouts at 16 weeks. This was a small study, only 30 patients. 66% received Spesolimab and 44% received placebo. They saw a 37%, almost 38% drop in EASI score at week 16 in the active arm versus 12.3% in the placebo arm. And the EASI 50 was 30% in the active arm and 5% in placebo. And EASI 75, 15% versus 5.6%. There were some serious adverse events that were reported that were slightly higher in the active arm than in the placebo arm, the details of which were not provided in the abstract. Moving now to biologics that target OX40 ligand, which in theory may be able to reduce T effector cells while not affecting T regulatory cells. This again was a proof of concept phase 2A study presented by Dr. Stefan Weidinger, looking at this new product in severe adult AD patients given IV for 16 weeks. This drug was given at a high dose and a low dose. And interestingly, they saw a greater change in EASI in the low dose treated subjects with 80% drop in EASI versus the placebo control of about 49%. Whereas the high dose had a drop of only about 70% with a placebo drop again of 49%. Those two doses showed no difference in the speed of onset of improvement or the magnitude of the response statistically. The response was different from placebo as early as week 2, and so far the safety profile looks quite unremarkable. Now moving to a drug that instead of targeting the ligand for OX40, targets OX40 itself. This was presented by Dr. Emma Gutman-Yaski. This was looking at 275 subjects who got randomized to 4 different doses of this biologic, and it targeted adult and moderate to severe AD patients. And you can see that there is a general dose improvement in the total percent drop in EASI, or the EASI 75, or the percent that achieve the IGA 0/1 goal, or those that have a greater than 4-point drop in their baseline peak NRS. But interestingly, the peak benefit is seen at the 300 milligram Q2 week, and you don't achieve what appears to be an added benefit by going to 600 milligrams Q2 weeks. So you seem to max out at the 300 milligram Q2 week dose. These benefits are pretty notable. And importantly, the most frequent treatment-emergent adverse events were pyrexia, nasopharyngitis, worsening of atopic dermatitis, and chills. So in conclusion, we reviewed the treatment landscape for moderate to severe atopic dermatitis and demonstrated that it's changing very rapidly. In fact, you saw that many of our guidelines of how to treat moderate to severe atopic dermatitis patients need updating badly. We have targeted biologic therapies, specifically dupilumab, which we now know is safe and effective for patients aged 6 years of age and over with moderate to severe atopic dermatitis, and many of these patients have now been followed up to 5 years for safety and efficacy evaluations. There are a number of other therapies that have recently been approved or in late stages of development, including Tralokinumab, Nemolizumab, Lebrikizumab, Spesolimab, and OX40 or OX40 ligand inhibitors. It's a very exciting time now to be a doctor treating this disease, as we are really confident we will be able to offer our patients many new therapies that we think are both effective and safe. Thank you so much for joining us for this educational activity. We hope you are as enthusiastic about the new landscape for treatment of our moderate to severe atopic dermatitis patients as we are.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RSD860. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals.